on the ESHRE good practice recommendations on recurrent implantation failure. I'd like to start with my disclosures, which I've given here. One I would like to highlight is that I am co-chief editor of RBMO, a journal which I hope is known to all of you, and to encourage you on this occasion to submit all your best work to us for consideration for publication, and I look forward to receiving it. So let's get to the topic in hand. And the idea of developing a guideline for practice is always challenging, but perhaps particularly so for this topic, because the task that was presented to us might have been seen as almost impossible, since we were being asked by ESHRE, the working group, to develop a guideline for a topic that many of us would argue about the definition, which we're not even sure these days actually exists as a clinical condition, if you read the recent literature, and for which we don't know the cause. So in many ways this would appear to be impossible. But we have to address it, because we all see it every day, and we recognize the stress and the distress that it causes our patients when they have serial failure from IVF after having the transfer of ostensibly good quality embryos. So let me start by introducing to the people I had the pleasure of working with as we put together this guide to good practice. On a process which carried forward with standardized methodology, which I'm just going to summarize for you here. How did we do it? The first thing to do is to look at the literature. And this was carried out with the huge support of our colleagues from ESHRE office to look at the evidence of the efficacy of different tests and different treatments for recurrent implantation failure. But relevant to this too is what is actually done in clinical practice. And this is particularly important in an area such as this, where the evidence base is actually quite thin. We need to see, well, what can we learn from other sources of information? And one of those is what senior colleagues are carrying out. So we were able to access recent publications which had summarized this, and that was very helpful. The third thing we need to do is look at the biological rationale for interventions in recurrent implantation failure, because even though there may be a lack of data from randomized clinical trials of interventions, we can surmise the potential value of some, particularly newer ones, based on what the biological rationale would be for them perhaps having a role in either the investigation or the management of implantation failure. And the fourth arm was obtaining the expert opinion of members of our working group, but also the broader ESHRE family, particularly the special interest groups. And putting that all together, which was a long task and quite challenging, results in a draft of recommendations, which is then put to stakeholder review. And many of you may have participated in that. That happened this time last year. And from that, we are able to deduce a final and approved version of the Guide to Good Practice, which was submitted and accepted for publication in Human Reproduction Open, and many of you may have seen it appear in the summer of 2023. So that was, in very short summary, the process that we undertook to produce the Good Practice Guideline, which I'm going to present to you now. So there are three elements to the Good Practice Guideline in recurrent implantation failure. First, we need to talk about what it is that we're addressing, in other words, the definition of recurrent implantation failure. We need to consider the investigations that might be recommended when faced with this clinical problem. And the third one is the interventions that might be considered when trying to treat it. So let's start by tackling the definition. And this is no easy task. The definition, as many of you will be aware, has changed over the last 10 to 15 years as practice has changed. Not so long ago, it was not uncommon to transfer 3 or 4 embryos at every embryo transfer, and therefore one would only start getting concerned perhaps once 10 embryos have been transferred without success. But practices have changed, and now we are, as a norm really in most countries, just transferring 1 embryo. So this, plus the move to blastocyst transfer rather than day 2 or 3, and several other changes, has meant that the definition of recurrent implantation failure has changed, and to be frank, remains a topic of very lively debate. And this was similar when we started to meet to try and achieve a consensus on the definition of recurrent implantation failure. I'm glad to say our first meeting on this wasn't quite as lively as that pictured in this slide, but it certainly was a topic which we gave a lot of our attention to and had some very interesting discussion. So where did it result? Well, I think we have been able to land on a definition which is both clinically, pragmatically useful, but also rigorous enough to be applied in the literature. And let me take you through it. So here's a definition of recurrent implantation failure that the guide would put to you. Recurrent implantation failure describes the scenario in which the transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigations or interventions. Now, this would be perhaps appear to be a fairly vague one because we're so used to seeing this described in terms of a fixed number of embryos back. But what it recognizes is, firstly, that the recurrent implantation failure that is requiring our attention will vary in its moment of arisal between patients. So while one patient we might be quite anxious if they haven't got pregnant after 1 transfer, for instance a euploid embryo in a young woman, there may be other women in whom 3 or 4 embryo transfers might not be expected to produce a pregnancy, and therefore we wouldn't want yet to apply such a definition with the implications that would have for their further investigation and management. So let's just take this a little bit further. How might we use this definition in practice? So among ART patients, we have acknowledged the chance of successful implantation will differ significantly, suggesting that a one-fits-all definition is no longer appropriate. In patients whose failure to conceive thus far would be recognized as unusual for their prognostic group, investigations of underlying contributing factors would be reasonable to consider at that stage. And this implies an individualized approach, which is based on 2 primary factors on requirements in order to do this. The first one is a decision we need to take about at what point we think that this threshold has been reached. And in order to do that, we need to have a model to estimate the chance of implantation and pregnancy that should have occurred to date in that patient in front of you. In other words, given the number of embryo transfers they've had, their age and their other factors, what is the chance that we think they should have had by now of conceiving? And then the second decision we need to make, and one which again we discussed in the group, is, well, at what point, at what chance of having conceived would we consider that a threshold to initiate action? Now, I appreciate these are perhaps 2 quite novel ideas to digest at this stage, so I'm just going to take you through it in a little bit more detail. So let's talk about a model to estimate the chance of implantation pregnancy. Well, we do that every day in our clinical practice. When we sit opposite a patient, we'll be thinking, well, what are the prognostic factors present in this patient that will help me advise that patient as to their chance of conceiving in the next cycle? And those are very familiar to us. There will be things like age, perhaps some of their hormone levels, like the AMH, endometrial and uterine status, and any underlying clinical conditions they may have. We need to take into account embryo-related factors, such as cleavage speed, euploidy, and previous implantations of sibling embryos. There may be male factors like genetic disorders that will impact on prognosis, or external factors such as the performance of the laboratory and the clinic, and transfer policies and indeed legal restrictions, or in other words, the context in which we operate. Now, ideally, when we're thinking about the chance of a patient conceiving with their next embryo transfer, we would take all of these things into account in order to assess their individual chance. However, that's going to be impractical in present practice. And therefore, what in practice we might wish to do, it would be to use the ART Centre's own data, published data, or published prediction models. And in doing that, we will come up with a means of estimating that patient's chance of conceiving to date, given the number of embryo transfers they've had, and going forward if we were to try again. And this is going to be important for our recognition of the patient that requires additional help. So the next question is then, well, what threshold should we then apply? In other words, if a patient has had a 70% chance of conceiving by now and hasn't, should we be concerned or just keep calm and carry on and try again? Or should that be 10%? Well, if the chance is too high, let's say it's 95%, we will only get anxious about a patient if they've had a 95% chance of conceiving and it hasn't worked. Well, very few patients in practice ever have a 95% cumulative chance of conceiving anyway. So if that was to be the threshold to define recurrent implantation failure in that patient, it would hardly ever arise. Now, there may be some good things about that. It means that those patients that are titled as having recurrent implantation failure would be few. They would have quite an extreme phenotype and would be great for enriching research cohorts. It would also be consistent with a biological concept that is emerging that true, real recurrent implantation failure is likely to be rare. However, there are some downsides to that in routine clinical practice because it doesn't recognize or engage with the realities of our practice and patient expectations. What I mean by that is that even if a patient hasn't had a 95% chance, they're going to start getting very anxious if it hasn't worked after a 50 or 60% chance. And we need to acknowledge that when we're caring for our patients. The problem is that if we set the threshold too low, in other words, we start thinking, well, if you've had a 20% chance of conceiving and it hasn't worked, I'm going to do all these extra investigations, then many patients with still a very good prognosis will be considered to have recurrent implantation failure and be subject to unnecessary interventions. These patients will feel taken seriously, which is great. But on the downside, these patients who may still have very good prognosis will be poor for research study cohorts, and it will needlessly increase their anxiety and interventions if we're doing these in patients who still have a very good chance of conceiving just by trying again. So this is all quite complex to get to grips with, but I do believe it's important to understand these, if we are going to produce a definition of recurrent implantation failure which meets all the needs of the definition. So having considered these two options of a low and a high threshold, what did we choose? Well, this followed a lot of discussion, and we arrived on a clinically relevant threshold being set at 60%. And this was done after presenting different clinical scenarios to colleagues, working groups within ESHRE, and then this was ratified by going through review. Let me put into words then what I think this means. So when a couple has not had a successful implantation by a certain number of embryo transfers, and the cumulative predicted chance of implantation associated with that number that they've had is now greater than 60%. In other words, by now they would have had a 60% chance of conceiving but haven't, then they should be counselled on further investigation and or treatment options. And this term defines clinical recurrent implantation failure for which further actions should be considered. So let me summarize where I feel we've come so far in this discussion for you. So the assumption for all of us is that any patient in front of us having IVF, if they've had failed IVF one or more times, will have had a basic fertility workup, and at least 2 embryo transfers will have failed to result in pregnancy. Otherwise, we couldn't call it recurrent. Then we ask the question, well, what was the cumulative chance of implantation pregnancy in that patient, given the number of embryo transfers? And if we come to the conclusion that the cumulative chance of implantation pregnancy in that patient is so far has been less than 60% and it hasn't worked yet, well, let's keep going. Let's keep trying. And we'll just proceed again with ART. If it's not successful, then we would assess the situation again. However, if we take the view that the patient in front of us has had, or thereabouts, around a 60% chance of conceiving but hasn't, given all the factors available, then we would suspect recurrent implantation failure as being a real problem in this patient that might merit further investigation and possibly even treatment. So let me take you through a scenario which is designed to illustrate this concept. So here we have a 36-year-old woman who has been trying to conceive for 3 years. She's got damaged fallopian tubes, she's never been pregnant and never had IVF before, and she's planning to use her own eggs. Well, using one of the online IVF predictors, and this is ones from Scott Nelson and Debbie Lawlaw, which you can access on the internet, ivfpredict.com, the following calculations can be made for this specific patient. Her chance per live birth per IVF attempt is around about 24%. Her chance of pregnancy per IVF attempt is around about 27.6%. So if we try once, twice, 3 times in this patient, or even 4 times, we'll find that after 4 embryo transfers, we would expect her to have had a 72% chance of achieving pregnancy, and after 5 attempts, an 80%, and after 3 attempts, a 62% chance of achieving a pregnancy. That is above our threshold of 60%. So if this patient comes to see us, having not conceived after 3 embryo transfer attempts, then we would classify her as having recurrent implantation failure that would merit possible further investigation and perhaps intervention. And if we were to change to a different patient, we would perhaps come out with a different number of embryo transfers to meet this. Now, what are the key factors? Well, we know age is an important one, but also increasingly the embryo quality. And given that, we've decided to come up with something perhaps a little bit simpler that can help clinicians in their day-to-day practice in a busy clinic guide them on determining which patients would merit further investigation because they have recurrent implantation failure, and those that we would just advise just to try again and not to be too concerned yet. So here's a simplified table where we've taken predictive models, we've put them together with some other data, and we've come up with a sort of a simple guide. So what you see here for patients where you have not tested for euploidy of the embryos, and that would be the case in most patients, that the maternal age is the key thing. So in women under 35 years, then they will cross the threshold of 60% after 3 embryo transfers. So if you've got a woman who's under 35, she's had 3 embryo transfers, hasn't got pregnant, you don't know the ploidy status of the embryo, then we would consider her as having recurrent implantation failure, meriting further investigation. If she's aged 35 to 39, that would be after 4 embryo transfers, and if she's over 40, it would be after more embryo transfers than that. So that shows you that we can individualize this definition or the application of the definition, and as women get older, they will need to have had more embryo transfers before we can label them as having recurrent implantation failure, because age will have been the most likely explanation. Now, in some patients, you will have information as to whether or not the embryos that have been transferred so far have been chromosomally normal. And in a situation of a woman under 35, if she has had known chromosomally normal embryos transferred, and she hasn't conceived after 2 embryo transfers, then we would advise this would be a moment that's worth considering possible other causes meriting investigation. For a woman between 35 and 40, and for a woman above 40, you will see that it's still at just 2 embryo transfers, because we know that one of the main causes of failure of implantation is aneuploidy of the embryos. But if any patient of any of these ages has had 2 embryo transfers of known euploid embryos and it hasn't worked, we've got to start thinking, well, what's going on here? If it's not due to the embryo, what else might be the cause? And that takes us then into the investigations. So once we've decided that the patient in front of us does merit further investigation on the grounds that I've explained, the working group has started looking at what investigations based on an extensive review of the literature. Now, I don't have the time today to go through these in detail, but I would refer you to our publication in Human Reproduction Online, which was published in June, or if you want all the data we gathered on this, then you can look at the document itself published by ESHRE, and I think it's available on their website. It includes all the supplementary tables. What is not recommended on the basis of the current evidence and knowledge is routine vitamin D testing, microbiome profiling, peripheral NK cell testing, or uterine NK cell testing. Now, this is balanced by some others that we would not recommend at this stage, such as uterine T lymphocyte assessment, blood cytokine levels, HLA-C compatibility, mitochondrial DNA content assessment, or DNA sperm fragmentation. Now, there may be clinical situations where you will think, well, actually, in this case, this could be worthwhile, and that, of course, might indeed be the case. But from a generalist point of view, at present, the data would suggest that these are not recommended in the investigation of recurrent implantation failure. What about interventions? Well, we use the same approach, and again, extensive literature searches, consideration, discussion, debate led us to arrive at the following recommendations. So in terms of interventions, we would recommend a review of estradiol treatment in preparation of the endometrium, particularly if it remains thin. We know that this can be a very difficult situation to manage, but some women will respond to additional estrogen, so have a look at that. Genetic counseling, and where relevant, pre-implantation genetic testing if a chromosomal abnormality is detected, and optimization of lifestyle factors. We can consider antibiotics if chronic endometritis is diagnosed, and PGTA we feel can be considered and may indeed have a value in some cases. And blastocyst stage embryo transfer, if it has not been tried to date, may be a way of increasing the chance of implantation occurring. What we don't recommend is a longer list at this stage. Treatment for vitamin D deficiency hasn't yet been shown to improve outcomes in this cohort of patients. Intentional endometrial injury is something that's still under review, and this recommendation may change in the future, but at the time of producing this, the evidence was not strong enough to recommend it. The GCSF administration and the intravenous installation of a number of factors that you can see there. The use of low molecular weight heparin, GnRHA and aromatase inhibitor pretreatment or assisted hatching. So these investigations at the present time, based on the information that was available to the group, are not recommended. A very important part of this, and I know this will be reflected for you in your practice, is our role in managing patients' expectation, disappointment, and to encourage them in many cases just to keep trying. And that's why counselling and patient care is so important, and why we've also included them in the Guide to Good Practice. Managing expectation is very important. Many patients, as you know, will often have unrealistic expectations, and if people are to continue with treatment, we need to be encouraging as far as we can, but also realistic. In that way, they may be able to cope with failure better and still be resilient enough to continue. We need to listen to and acknowledge the feelings of the patient, of the couple, respect their wishes and choices, and this is important in this age of evidence-based medicine, that we must remember that the patients are partners in care, and they may have a particular need or wish for an intervention for which we feel the evidence base is not strong, but on reflection we may feel it will help them in their process to at least have tried it. And this is perhaps a controversial opinion, but I think it does reflect the realities of clinical practice. We use clear and sensitive language, explain terminology, avoid insensitive terms, and we have to be honest about processes, likely outcomes, prognosis, but also the evidence base or lack of it for the investigations or treatments we are discussing. That is absolutely important. Many of them will be able to be reassured based on their individual estimation of their likelihood of implantation in the next cycle that the best thing to do is just to keep trying and not to have any further investigations at this time or further interventions. Because half of patients with the old-fashioned diagnosis of recurrent implantation failure, which many will have used as being 3 embryo transfers without success, have been shown to achieve a live birth within 5 years of that diagnosis. So yes, keeping going will be the answer for very many of our patients. And in the end, we need to make sure we're applying a shared treatment planning in a partnership approach. And I think that is something that we will all try to do in our practice in these days. So to finish off, I have had to go through this very quickly, and there will be many questions I'm sure you'll have about specific treatments or specific investigations, or indeed the rationale for defining recurrent implantation failure as we have. So I would refer you to this paper that we published in the summer, which I hope will be able to address most of these questions for you. And as we look ahead now to the future, I think we do need to still reconsider recurrent implantation failure very profoundly. And there are narratives ongoing at the moment that would suggest that recurrent implantation failure is a pure construct of doctors and it doesn't actually exist as a biological phenomenon. And there may well be something in that, but in clinical practice we do see patients who are frustrated that they haven't succeeded yet, and we have to manage them. The problem is that we've tended to think of recurrent implantation failure as a medical diagnosis, and it's not. It's simply an experience, isn't it? It's a situation. It's not a diagnosis. And our clinical practice has tended to be, let's just try something, try anything, or keep going. And this is a rather untargeted and perhaps biologically weak rationale. So as we move to the future, we should be aiming to recognize recurrent implantation failure as just a symptom of an underlying problem which merits investigation by diagnostics, and those diagnostics are beginning to become available to us at both embryo and endometrial level, and to treat the cause of recurrent implantation failure and not the symptom. And what I mean by that, for example, is if you've got a patient who's failed to get pregnant despite 2 or 3 embryo transfers, and you think they should have, don't just give steroids or heparin blindly, because there will be some patients who are perhaps doing more harm than good. So before using these things, we should be thinking carefully as to whether there is a rationale in that patient for using them. And that will in the future require more diagnostics.